All right, good morning, everyone. Good morning. So I don't have slides, and I'm really short, so I'm going to see if I can step out and talk this way. But so I'm Lena Wen, and I am really honored to be here today. And I wish to thank the dean, thank all of you for allowing me to be here, really to join this panel of my public health heroes. I mean, this is one of the problems of speaking after Dr. Buehler, Dr. Bassett, Dr. Buford, that I feel like I have nothing much to add, except to say that I'm really happy to be part of a group that isn't just about admiring the problem. I feel like so often we present statistics, we present the problem, and we spend a lot of time looking at these disparities. But we don't talk about what is it that we should be doing, how we can be putting research into practice, what are the actions that we're taking in different locales around the country. And so really delighted to be here to join a group to talk about what are the things that we are already doing and what are the things that we could be doing better. And I love this is maybe my inner public health geek coming out. But basically everything that was said earlier by our speakers, I kept on thinking, yes, this is great. Using public health as a tool for social justice, fantastic. And so I'm glad to be here to join in this with this group that will together, I think, be fighting some of our most difficult challenges together. So I come to you from Baltimore, and I think that many of you have seen the images of Baltimore in recent days. And the images are not good. We've seen hundreds of cars being burned, dozens of buildings being looted and destroyed. We've seen individuals as the perpetrators of violence and individuals getting arrested. And we've seen, for example, also the story of Freddie Gray. And whatever happened, whatever we may feel about police brutality, about institutional racism, we also have seen public health in the news. We've seen that Freddie Gray, for example, was a patient who had lead poisoning as a child. We've seen that Sandtown, Winchester, where Freddie Gray lived, has a nearly 20-year life expectancy difference with neighborhoods that are right next door. And for better or worse, I do think that it's put Baltimore and public health in the spotlight on a lot of issues that might not necessarily be good, right? We're talking about poverty, we're talking about violence, we're talking about disparities. But I think it also gives us a framework for discussing what we can do moving forward. And as was mentioned by Dr. Bassett, Dr. Buehler, and others, this is not just a matter of statistics. But these are the people that we're serving. These are our residents, these are our neighbors, these are our family and our friends, and these are the lives of people in our cities. So I want to give you 3 ideas to think about. And I hope that these ideas apply to us no matter which city we're in, no matter if we come from academia or whether we come from the practice and government and foundation aspect as well. So the first idea is that we in public health, especially in urban public health, have to go to where people are. Go to where people are. And so, with the Affordable Care Act, there's been a constant debate, and I think all of us experience this in different ways, about whether we should be providing direct clinical services as the public health agency, or whether those of us in academia, what is our role in direct care? What should we be doing? And I'll tell you that in Baltimore, I would love it if we did not have to do immunizations or school health, right? It would be great if every single student had a primary care doctor. But that's not the case. We have 85,000 students in our city, in public schools, out of a population of 620,000. That's a lot of people in our city. Basically, 1/8 of our population are in schools of some kind. And every year, we just had the start of school, we have thousands of students who don't have their immunizations. That's the reason why we believe in staffing we staff all of our schools with a nurse or nurse aide or nurse practitioner. Because it's not that our students are going to be able to get care some other way if we don't have these services available to them. So it's important for us to provide those stopgap services in that meantime, and to prevent, for example, students from waiting for many hours in the ER in order to get services that can be provided where they are. I'll give you another example of this as well. In the middle of the unrest, we saw what happens when there are services that are disrupted that we cannot even possibly have imagined. I mean, we never planned, for example, for dozens of our pharmacies to be burned down, looted, and otherwise destroyed. And I remember at that time when we were in the middle of thinking, how safe are people going to be? How safe are our staff going to be? How safe will our staff who are going to do home visits going to be in the community? We also heard stories of our patients, from our patients and our residents who were not able to get access to their basic medications. I remember this woman called our 911, our 911 line in the city, our 311 system. And she was so short of breath that she was speaking like this. And I thought maybe she was out of her inhaler. But actually the medication that she was out of was Coumadin, because she had pulmonary embolism and was being treated with Lovenox and Coumadin for her PE. And so she was literally dying because she was out of her medication. So we had to figure out then how to get people access to these meds. And I remember calling these pharmacies. We called Walgreens and CVS and whoever was in the city, and they were saying, well, we don't understand the big deal, because there are dozens of other pharmacies, actually hundreds of other pharmacies in the city. Why can't people just walk a few extra blocks to get their medications filled somewhere else? Well, imagine if you're a patient who uses a walker, who's on oxygen. Maybe you don't even know, you're watching the news and you don't even know whether it's safe to walk out your door, because to everybody else, it looks like the city is burning around you. How are you going to be going a few extra blocks? Or maybe you get your prescriptions filled at Walgreens, but actually now you have to go to a CVS. How are you going to get that filled when your doctor's office is closed? And so for us in the health department, but I think also as a city, we had to figure out how to get people the care that they needed where they were. And so we set up a 24/7 prescription access service so that people could call us. And we literally hand-delivered prescriptions, which is not something that we're set up to do, right? This is not one of the core services that we provide. But I think because of the nature of our work, because what we do is to go to people at their time of need, wherever they need help, that's why we were able to deliver that service. And actually this, I think, was an example of a good partnership with our universities as well. We had students from the Hopkins School of Public Health, we had students from Maryland, from Morgan State, from Coppin State, come and help us, literally hundreds of volunteers, do outreach in senior buildings, do outreach in churches. We went to hundreds of churches and senior buildings overall within a matter of 3 days, so that we could let people know about the options that were available to them for food access too, right? People were also using our pharmacies for food, which is one of the big problems that we have, that 1 in 3 African Americans in our city live in a food desert, compared to 1 in 12 white people in our city. And so I think that it's those examples of going to where people are and using credible messengers for that service that we have to preserve in public health. One of the programs that we run, and I know that this is a program that exists throughout the country through something called Cure Violence. In our city, we call it Safe Streets. And we hire people who are often ex-offenders themselves to walk the streets and to mediate conflicts where they occur. So last year in Baltimore, our Safe Streets employees and contractors mediated 880 conflicts, 80% of which, 4 out of 5, were deemed to be likely or very likely to result in gun violence. Now, it's hard to quantify exactly how many lives this could have saved. But I think this is an example of something that we do in public health where, again, we go to where people are. And we have credible messages. You don't want me walking the streets of Baltimore in neighborhoods saying, put down that gun. The best way to solve this conflict is not through gun violence. I don't know that that's going to work so well. But we have people who come from the communities that they serve, who often were themselves drug dealers, who were convicted themselves of various things, but who are able to go back and serve people where they are. Now, I want to give you a second idea. And the second idea, and one that, again, I feel like now that I'm following this other people, I may be repeating a little bit, but I'll give you a couple of examples from Baltimore of why it's important for us to change the conversation and to shape the conversation in a way that puts public health out there in a proactive way. Because So often we think about, if you ask people, if you go to a community meeting, as we often do, and go to a community meeting, you say, what is public health? So often people will talk about rats, and they'll talk about trash cans, and they'll talk about public services, and they'll talk about health care, as in the health that you get in the hospital. But they don't think about the other work that we do in public health. And so we have to talk about what that may be. And we have to talk about this in a proactive way. And we also have to talk about things that work, especially in Baltimore where we have so many bad things that have happened. We want to talk about our successes as well. So let me tell you one of them that we're particularly proud of. Back in 2009, our city had the 4th worst infant mortality in the country. And but it was not for lack of trying, right? There were literally hundreds of groups, community-based organizations, sororities, fraternities, and the city working on reducing infant mortality in different ways. So we decided that we were going to band together as a city and have all of these different agencies work together under one umbrella, the Be More for Healthy Babies umbrella. And as a result, we have now celebrated this last year the lowest infant mortality that we've ever had. We had also, for lead paint, for our prevention work, we had an 86% decrease in the number of children who suffered from lead poisoning between 2002 and 2012. It's important for us to change the conversation from things that don't work to also talk about the things that do work as well. Let me give you a third and final idea, and this is one thing that we are also struggling with in Baltimore, that so often we have to think about our long-term strategy, and that's really important because we can't just talk about the low-hanging fruit that's right in front of us. But we also do have to show short-term wins as well. For us, when we look at the violence that's occurred, we have to talk about trauma. But what's underlying violence and trauma is also substance abuse. It's also unmet mental health challenges. And so how can we show, in these problems that have taken root over generations, over decades, how can we also show some short-term wins as well? So for us, for example, we've been focusing on overdose prevention because this is a matter of saving lives. So this year, for example, we've increased our overdose outreach and training by over 400%. This year, we've already trained 3,000 of our residents, not just our police officers and first responders, but also family and friends. We're doing outreach on the streets. We're doing outreach in jails. We're working in shooting alleys to talk about the importance of all of us saving lives. And I think that's an example of course, we know that preventing overdose is really the last part of what we can do, right? This is really, we want to focus on prevention, we want to focus on getting people to long-term treatment, but if we're able to show tangible outcomes, intangible metrics when it comes to very specific things in public health, then that's one way of us showing our residents too that we're listening, that we care, and that we are working towards our goal of it not only improving health, but also of addressing social justice as well. Now, I know that our city has been in the news again for many bad reasons recently, and that there's so much work for us to do to rebuild that trust, to regain our sense of justice, and also to work together with our community so that it's not just top-down saying, here are policies that we have to enact, and that all has to happen. But I also think that this is an opportunity for us in the city, in Baltimore, to show that we can be an example of urban renewal of sorts, that we can rise and say that we're shaping our agenda as a city from a public health approach, that we can really do health and health policies as it applies to education, to employment, to violence prevention, to everything else. And I'm hopeful that our lessons in Baltimore, just like our lessons throughout the country, will be able to allow us to really fight these deep-rooted inequalities and address the deep-rooted public health challenges that we all face. Thank you for the opportunity to be here, and I look forward to learning from you during the rest of the symposium.
Lena did a great job, right? That's the future of the public health leadership, and I want to thank the dean, too, not just for inviting us, but for putting practice at the beginning of the session to say, okay, well, so here are the people who are across our country who are struggling with these issues, and then spend the rest of the time helping us by coming up with good strategies. Many of the issues for Los Angeles look very much like the maps you've seen. South LA looks like the South Bronx. It looks like Central Philadelphia. And you don't need to see the maps because we have the same disparities, we have the same social problems. I want, like Lena, to focus on at least some hopes for solutions that people on the symposium can spend their time helping us to see which of these is the most likely to move us forward. So I think Lena touched on this, but I think a broad part of the premature mortality in cities across the US is the interlocking epidemics of substance abuse, mental illness, and homelessness. You can't separate them. They occur in almost all the same people at one time or another in their lives. But that has to be addressed. In the absence of addressing that, I don't think we will make any sizable improvements in many of the things that don't necessarily, except if you're in a clinical context, see how those things drive diabetes, how they drive hypertension, right? So I think it's those things that have to be dealt with. If we're going to deal with those kind of complex social problems, and I always watch, I'm a native New Yorker, and so even though I've been in California for 30 years, I know more about Mary's department, right, because I read the New York Times every morning, right, so there's she, so I'm like, what's Mary doing about homelessness? Because I have to figure out, you know, our response in Los Angeles. I think that there is a tremendous amount that could be gained by doing more collective impact work. And Lena again touched on it. I think site-based is an example of collective impact. But I think what you would find in any of our cities, if you looked at any of the social problems, and right now I'm focusing a lot on homelessness in Los Angeles, it is not for a lack of committed, courageous people and organizations that there is growing homelessness in Los Angeles and in New York and other places. I mean, some of it is the economics, some of it is the substance abuse and the mental illness. But we are failing to work together. We have all of these agencies, people separately funded. They are going and doing good things, but they are not aligned to actually end homelessness, as one particular example. And it would only be if we were actually to align, and a key issue of alignment under the collective impact model, it's not just that we're all going to come together around a single table and like each other and know each other. It's that we're going to create a single metric. So what that would mean in the case of homelessness, say, is that all of the people working on homelessness are working to house the homeless. Now, currently, certainly in my city county, that would not be true. Some of the efforts, including some very good efforts, probably increase homelessness at least, or at least change where people are homeless. So Skid Row, which the first time, even as an urban person who lived in New York City, lived in San Francisco, I was shocked the first time I walked through Skid Row in Los Angeles because I had never seen a whole block of wheelchairs on the sidewalk all right next to one another. LA has actually concentrated its homelessness more intensely than many other cities. They have the same homelessness as somehow LA really has it in the Skid Row. Well, one of the factors towards that is that you have several missions that are doing absolutely God's work in creating shelter and food, but then everybody gets tossed out in the morning because that's what they do. They do the evening meal and night shelter. So you have a draw into Skid Row, but then you don't have any way to get people into housing, right? So then Skid Row grows. So how do you a collective impact answer may be that, and as we're going to start working on, okay, well, sheltering people, feeding people, those are good things to do, but we need someplace for those people to go during the day, right? We need job placement, we need job employment, we need meaningful activities for those people so that they are not just out on the street, and we need for people to focus on housing them as a way of dealing with homelessness. A second theme that I hope people will work on is how do we really engage the healthcare delivery system to spend money on addressing social determinants. It's a huge opportunity. So like many of my colleagues, I do the two roles of being a clinical physician and being a public health person. I can, for my homeless person who comes in, I can order them in my system an MRI scan. I can order them a CT scan. I can get for them expensive medications. Can I actually house them if using health dollars, if that were the most effective intervention? And the answer under Medicaid is no. It's a hardwired, written prohibition against the use of healthcare dollars, Medicaid dollars, for housing. But there may be ways around that. In fact, we know there are ways around it. The federal government could allow under Medicaid that people could be housed using incentive payments to providers or health plans for housing the homeless. So just as many providers receive incentives for decreasing hospital-based infections or increasing mammogram rates, the federal government could provide incentives to house people. The beauty of this is that there would be tremendous savings on the Medicaid side or healthcare side. It doesn't have to be a US-only answer. The principle is the same, that when people are homeless, their medical care costs rise because their substance abuse worsens, their mental illness worsens, they're vulnerable to a variety of illnesses that bring them in the hospital. But we then participate in this cycle of dealing with the medical illnesses and not dealing with our ability to solve it. Homelessness, for example, is a solvable problem. You solve homelessness by housing people. It's not actually that hard to do. We've done, in Los Angeles over the last 2 years, we've housed 900 people purely using healthcare dollars. I just took dollars that we were spending in the hospital and in the emergency department for homeless people, and I put it to housing them. I moved people directly out of the ED and out of hospital beds into housing. That program can work. One of the things it requires, and I think this symposium is perfect for, is it really requires that public health people and healthcare provider people work closely together to identify the opportunities so that we can move money to take care of the individuals in the best possible way. The third of the four solutions I would like to suggest to you is empowerment. So I think one of our failures in addressing some of the social problems that face cities is that we're stuck in a service model, right? That is to say, I'm sending you, again, to use the homeless example, my county spends a fair amount of time counseling people about the stresses of being homeless, right? Well, you know, it is very stressful to be homeless. Very stressful. How do you deal with those stresses? Right, well, it would be obviously better if you could house people, but in general, what I'm trying to say is that I'm not sure that we succeed if our model is always, what is the service I'm going to provide you? So, for example, one of the things we try very hard to do in our housing program is to hire formerly homeless people to run the front desks of the future housing programs that we create. And part of how you make a community more highly functional is to really tap the energy. People need meaning. People need work. People need a reason to get up in the morning. You know, when often in programs that are focused on service, however well-meaning they are, they're actually disempowering, because they reflect the idea that you are going to help this other person. They don't sufficiently tap into the question of what that person could actually do. There's a wonderful model in Los Angeles, not a county model, completely self-sustaining, called Cristales. It's an employment agency. They help people find jobs. But the way they sustain themselves is they run a for-profit business cleaning city streets as part of improvement districts. So they hire people, they clean the streets, they gain revenue, and they use that revenue then to help other people to find jobs. And the basic idea is that, and I know, it fits the experience that New York has had and San Francisco has and LA has. You have to worry that you keep providing housing, but it seems like there are still all these homeless people, right? Which then causes a certain taxpayer cynicism. Well, you said you were housing people, and now I look and see all these people are homeless. What's going on? And it's because we're not getting anyone out of the system, right? So we're just growing the system. And ultimately, that's going to fail. So we have to make sure that from these systems that we're creating, there are people who graduate, that it's a positive thing. They graduate to better jobs, they graduate to better housing, they graduate from intensive mental health programs to self-help mental health programs, to helping other people, to serving as peers in mental health programs. And so that you don't just grow the programs always bigger, but you figure out how can people graduate. And then the last issue that I hope you'll take up today is incarceration. So LA, and this also fits Mary's sister agency, New York Health and Hospital Corporation. New York and LA are taking over the health care in the jails. And I think part of the opportunity there is jails, unlike prisons, are for short-term stays. So the LA jail, 17,000 people are in the LA jail on any given day. At least 30% of them have a mental illness so severe that they're requiring an antipsychotic. Probably 80% of them have a moderate mental illness and/or serious substance abuse issue. 1,100 people are released every day from the jail, and 1,100 come in. Where do those people go? Where are they released to? Right, they're released with a bus token to Skid Row, back to the place where there are all the people who don't have housing. And as we're incarcerating them, what happens? Well, first, of course, they lose their benefits, right? The counties pay from general fund instead of being able to pay for Medicaid or some other fund for the individuals. Their mental illness and substance abuse, does it get better in jail? No. Of course, it gets worse in jail under the stress of the conditions of incarceration. So whatever your views are of our prison system, and mine are not very favorable, right? The United States now incarcerates more people as a percentage than any civilization ever has. And if you want to talk about the disparities, right, I mean, there's no greater disparity of black and brown than in the jail compared, to any other place. So we have this, awful disparity where we're putting people for very short periods of time, serious mental illness and substance abuse problems, and those problems get worse because there is insufficient ability to treat them, and because the conditions of the jail actually make them worse. And then they get released. And I'll close on this point. If you think I'm focusing too much on this small group, think of how this small group is connected to their families, right? To families that don't have a wage earner, to the experience of violence, to the experience of the kids who are growing up in those families, to the emergence of these large numbers of kids in foster families because that it's this narrow group, and that we have to address the needs of this narrow group if we're going to make the broader neighborhoods and communities healthier. Thank you so much.
I don't know if you have noticed, I noticed outside that says Public Health Human Rights in the logo of this school. And what we have been listening now is equity, healthcare and public health, response to clear needs, homelessness. Wow, this is a really an incredible agenda that has been posed by the commissioners, and thank you very much for the framework. What I want to address now is to bring you out of your cities, out of your country, and to take you to the other dimension, to the global and regional dimensions. The world is watching you, and really, so don't be scared. The world is watching you, is watching what you do. That's the problem of leadership. When you have leadership, people will be watching you. But I just want to make you aware that you have also watched and you have learned a lot from the world. For example, the closed streets on Sundays and weekends. That was first started in Bogota. The bus rapid transit systems, the BRTs, they were started in Curitiba, in Brazil. So you have learned as well from the world. So I want you to just to change you to a different setting. So I will try to provide a quick review of the global and regional processes and open a discussion on how you can influence and use such processes for your benefit. I don't want you to read all this timetable, but this basically since 1972, the World Human Environment Dimension started all the things that have been happening, but if we focus on this part, in 2007, the WHO Commission on Social Determinants of Health developed a knowledge network on urban health, and this network provided a framework to try to understand what is happening inside our cities. And I will not go through the details, but basically what you have is to acknowledge that beyond your place, your local city or municipality, there is a global and national context. You were talking about direct funding from the federal government to the cities. Well, there is a national context, but there is also a global context. And we have to act between the municipal determinants and the conditions of people. And that is where we act if we want to influence the final health outcomes. One of the key issues that this network raised is the issue of slums. You were talking about homelessness. Well, in many areas of the world, and here also in the States, poor housing is one of the biggest problems. And here, one of the issues that were raised is the problem of slums, and this was considered in the 2010 WHO World Health Organization and United Nations Habitat Report, the Hidden Cities Report. What this report said is that the majority population is now urban, and that we have had an incredibly fast increase in most in urbanization, and this has become a major global issue. Here in the States, your rate of growth in cities has been more paced, more slower than what you have seen in the developing world. And this has become one of the most important global health issues. This has outpaced government ability to tackle with that. There is a disproportionate amount of poor health, as you have shown, because of the poor living conditions. And we require local involvement of communities and of governments. So it is true, we need the empowerment of people, as Mike just mentioned. Well, this was taken in 2010 to this initiative of World Health Day by WHO on how we mentioned 1,000 cities, 1,000 lives. And basically trying to call to 1,000 cities throughout the world to say, hey, what are you doing and how can you tackle health? Well, this call was at the end manifested by a meeting in Kobe, Japan. Not all the 1,000 mayors attended, but a lot of them attended. Not only 1,000 cities registered what they have been doing, but 1,500 of them. The 500 came from China. So they were able to provide a lot of that. But I just want to highlight what those attending that meeting in Kobe committed to in this call to action. They said, we commit to promote health and health equity in cities. So the issue of equity, what you are raising, was committed clearly in that meeting. We commit to collect and analyze data in a disaggregated manner. Before that, this was hidden. That's why the report is called Hidden Cities, because we don't see these inequalities. They commit to intersectoral action. We commit to assess the impact on health of urban policies and programs, other policies, how they affect health. Use urban planning, really insert public health into the urban planning processes, and provide the space for citizen participation, something that might sound common for you, but in most not so democratic countries does not happen that easily. Here you have, in the case of the Americas, for you to see the issue of inequity in some cities in the Americas has improved, but in others it has not improved. We have very large cities in the Americas that have been growing over the last few years. So that is why the countries of the Americas met together and asked the Pan American Health Organization, that is the regional office of the World Health Organization for the Americas, and the Americas include from Canada to Patagonia and the Caribbean. They asked the PAHO to develop and to bring a consensus on a regional action plan. So believe it or not, United States promoted this, and United States was a heavy supporter of this initiative. And I remember clearly Niels Delaire from the Department of Health and Human Services talking in the opening meeting of the Directing Council, calling for all the ministers, listen guys, we have to pay attention to urban health. So it was approved in September of 2011, the Regional Action Plan. And the Regional Action Plan is focused on strengthening institutional capacity on stewardship and provide the ministries of health and their departments of health at the local level on focusing on urban health planning, centered in people and in communities. And the plan has 5 lines of action, one on policies and plans on urban health planning, the health services reorientation, exactly what Philadelphia is doing, regulatory frameworks and governance, use the power of regulations, use the power of the health authority, as New York just mentioned, national and regional healthy urban municipal networks, use the networks of municipalities, of city mayors, of city commissioners to bring this together and strengthen the knowledge, information, and data exchange, the research, and the health impact assessment tools. The Regional Action Plan provides and asks countries to use different tools. There is an urban heart tool that you might know. It's basically what you are doing in your maps, but trying to go behind it, trying to go into the causality chain and trying to look to the health determinants and put them together, your maps with the health determinants. The health impact assessment of policies, plans, and programs, the urban health observatories. Here we have from Brazil a very good example of your urban health observatory, a way to systematically collect data and put it clearly on the table for decision makers. The development of guides. Here you have one of my pet guides, the active design guides that were developed intersectorally, interdisciplinary, with public health working with street designers, with architects. Really fantastic, fantastic tool that we want to bring it, make it available for everybody. The networks of municipalities. Here is the Mexican network, one of the strongest in the region, but there are many other ones. And use the partnerships. And we launched in New York, by the way, and Joe Buford was part of this, the first Wellness Week. The first Wellness Week that is going to start in this weekend, now related to parks and health. What's the Association of Health and Parks? And this is happening, the Wellness Week, now throughout the whole Americas. This was taken in 2011 also to the UN high-level meeting on non-communicable diseases, where urbanization was clearly identified as a cause and as a factor for NCDs. And the political resolution of 2011 called for work on the urban setting. Joan was talking about the Sustainable Development Goals. Yes, in the year 2000, we as a planet, we decided to support developing countries' poverty reduction initiatives, as if poverty was only there in developing countries. And you have shown that happens all over the world. Okay, SDGs now is focused on every country of the world. So it's an all-country focused on economic, social, and environmental pillars of development. And it has 17 goals. Why are we working on this? Well, the 8 Millennium Development Goals proved to be a quite successful experience. Most of the countries advanced, and most of the goals, the ones in green, were achieved. Some were more or less achieved, and some were not achieved. So I would say this is a successful story for the world, and mainly if we think that these were developing countries. Now, in a few weeks, New York City will be crowded with all the people attending the summit on sustainable development. They are going to discuss 17 goals, where we have a third goal on healthy lives for all ages, and an 11th goal to make cities and human settlements inclusive, safe, resilient, and sustainable. Okay, 17 goals in total. Every country, every citizen can reflect themselves in these goals. And all these goals are interrelated. And that's the beauty of this assessment. Here you have cities, here you have health and cities, okay? But they are interrelated to each one. How are we going to work on this will be part of the trick. But health is interrelated to other goals, and including cities, and the International Society on Urban Health has taken this in the Dhaka Statement on Urban Development. What's next? Well, after New York, we have Paris. Paris is going to focus on cities. On what? On the climate change agreements. Hopefully, there will be finally a climate change agreement, a global climate change agreement. And cities will play an incredibly important role. Fortunately, last week, the meeting in Bonn was not very successful. So I am a little bit concerned, but we have to work, and please, this network of cities for climate change has to work on that. Next year in Ecuador, in Quito, Ecuador, we will have the UN Habitat 3 meeting. I would say that's an opportunity to bring to the table the health agenda. The perspective is, yes, to have a city that is safe, but also to have a city that is healthy. So the invitation for all of you is to influence on and use all these processes. Cities have the potential to implement the local, national, regional, and global commitments. And here you have a set of global commitments that have been signed and approved by your country representatives in the global fora. You can work on this and use all the inventory of commitments for that. There is a role for you in the global agenda. The UN agencies and the UN countries usually meet here, but there are other organizations, and you play a role as non-state actors necessarily. And finally, you can influence on data, knowledge, social support of policies, implementation, and accountability. Thank you very much. And I stop just in time.
Okay, thank you. That was absolutely fabulous tour de force, and everybody touched on a really different aspect of the issues with the sort of same issues at the core, so great fodder for conversation. While everybody's screwing up their courage and getting ready to ask their question, I think we'll ask you to raise your hand and the mic will come to you. One of the things we didn't talk about too much, and I just wanted to throw this out to each of you, is the issue of governance. When you talk about collective impact, some people would say aligning interests is a kind of governance, but obviously government, which you all represent, is really important. So how do you get the political leadership to take on a health agenda, a public health agenda, in regard to the kind of support that you need? What are some of the obstacles? What are some of the strategies that you've created to make that happen?
So is that going to me first? Well, let me start. Yes. So that's obviously a really important question, because many of the communities that we've all been highlighting as bearing an excess burden of numerous poor outcomes. I mean, not just health, but education, mass incarceration. If we looked at which neighborhoods light up, it's the same neighborhoods, are neighborhoods that are deprived of political power. So in talking about going to neighborhoods, we have to acknowledge that we have also to deal with the fact that the policy environment of those neighborhoods not determined there. It's determined more broadly. In New York City, we're in a special situation because we have a Board of Health that has regulatory authority. That's one part. So our Board of Health, when it votes, it's passed a law. It's outside of the legislative process. So that is one part of it. And of course, the political leadership of the city is important. And New York City, for the first time in 20 years, has a declared progressive political administration, and this is also a great help.
You now have microphones. So
Yeah, we all have microphones. So I'll give it to you.
You don't all have to take it up, but if you're interested, please do.
In Philadelphia, we've had the very good fortune of strong support from our mayor, Mayor Nutter, who has been an advocate for public health, predating his term as mayor, as a member of city council, when he led the charge for Indoor Clean Air Worker Protection Act to outlaw smoking in restaurants and indoor spaces. We've had strong support from city council. I think our health departments vary in terms of the spectrum of things that we have under our umbrella, of what responsibilities may be the lead of other parts of city government, but they have a big impact on health. And so we need to be aggressive in working out, or reaching out and working with our colleagues in other parts of city government. I think one thing that's impressed me is that we do need to keep educating our political leaders about what public health is. A striking lesson to me was a number of months ago, we had a candidates debate in our mayoral primary about public health, and yet most of the conversation focused on healthcare. Obviously, healthcare is important, but I think we have to keep reminding our leaders about what public health is and what it is that we do.
Yeah, and I would agree with that. I think it is, it's our great challenge in public health, actually, to keep on putting this at the forefront of the agenda, because otherwise, I think it's easy, especially for our elected leaders, and this goes back to Joe's question about challenges, to do the whack-a-mole, right? You have the issue that comes up, and you immediately want that immediate solution. And for example, in Baltimore, when we see violence and unrest, immediately people think about, well, these are the perpetrators. Let's do something about the perpetrators. It takes a little bit of time to then focus on what about employment opportunities or education. And then we can say that we use that opportunity to say it's not just about violence, but violence is so closely tied to trauma. I mean, how many people in our city have not experienced trauma growing up, whether it's with poverty or whether it's with not knowing about whether they're going to have a house over a roof over their heads. And so how can then we redirect that conversation to talk about behavioral health issues? And so I think that's the challenge, but also the opportunity that we face.
Carlos and then Mitchell, and then we'll open it.
Yeah, just a quick idea. I do believe that we have to partner with the communities and with the other sectors within the city. And a great tool for that is sort of a barometer of what happens when other sectors do a policy and what's the impact of that policy into health. And we have to tell them, hey, what you are doing is improving health, and you are really having added value. So show the added value of some of the policies, and obviously show the lesser value of other policies for public health.
Well, no, I can just think of a lot of examples. For example, I have two microphones. I'm really feeling empowered here. For example, we had a number of very high-profile attacks violent attacks by people who clearly had a history of mental illness. The very public execution of 2 police officers in New York City was somebody who had a long history of mental illness. And as Liana was just pointing out, we can turn that into a criminal justice matter, or we can also, try and bring our political leadership and the population along with an idea that we have to take a longer view of this. So that often for people in public health is a difficult path to navigate, but we did succeed in doing it. And I think that taking advantages of situations as they come up as an opportunity to take them back to public health is really important. We also did an analysis on the impact of $15 more livable minimum wage. That is not a health intervention, but we did an analysis at the health department to show what the mortality impact would be. And that's an example of how we can show our politicians how they'll have a health impact, even when they're not thinking of it that way.
That's great. Okay, yes, down here? Just keep your hand up until you get the mic, and then I'll try to keep track. If you tell us who you are and ask your question.
Hi, I'm Andrew Issa from Drexel University. I had a question regarding gentrification and how has that changed what's going on around urban health. I know, for example, in Los Angeles, some of the issues that were faced in South Central are now going to Victorville or Vegas. And how have you collaborated with outside counties or cities and other states, and what challenges are faced when doing so?
Well, gentrification, I think, is a very interesting problem because it has both good and bad things, right? I mean, you're talking about the economic improvements, right? We want people to earn more. Of course, what we don't want is for a different group of people to earn more and come into the neighborhood and push out the people who are still earning very little. But I just say that as a way of saying gentrification is not necessarily bad, but it can be bad. And you point out a very interesting problem in South LA, historically African American. And in fact, our health department has Afrocentric health centers there, MLK, Humphrey. And the only problem is that 70% of the neighborhood is now monolingual Spanish speaking. Right, so I have Afrocentric health centers with 70% monolingual Spanish speaking, and the African Americans that are in my county that haven't moved to Vegas, they've moved to high desert where I have essentially nothing, right, because that's the cheapest place to live, but none of our providers want to live there in the Antelope Valley, so I can't get doctors and nurses to actually be able to serve them. So, while I have no answer, it does fit Lena's point about the dynamic nature of health. You have to go where people are, right? So we have now been opening service areas up in high desert to try to meet the needs of African Americans who are living there, because that's now where it's affordable.
Okay, let's go over the gentleman in the back, and then the lady in the blue sweater comes after. We'll go back and forth. And then the middle has to catch up.
Thank you. Going back to the first question and issue that you were talking about.
Could you introduce yourself,
Oh,
please?
sorry. Arthur Frank on the EOH faculty here at Drexel. You were talking about the political support that is needed, and I think it's fair to say that in places like New York and LA and Philadelphia, there has been good political support at the local level, and that's certainly necessary but not sufficient. We have a chair of the Environmental Committee in Washington who doesn't believe in climate change. We have a legislative body that's trying to do away at every turn with ACA and taking health care away from people just as you're trying to give it to them. So I'm wondering if you might want to comment at the larger level how we deal with those political issues, and maybe as a corollary, for those of us that are in academic situations, what can we do collaboratively with you or in our own way to help further education, perhaps not so much at the local, but at the national and perhaps international level as well?
Carlos, do you want to start with that one?
Well, that's not an easy one. Otherwise, we would have had a very successful bond meeting, and that was not the case. I do think that now that I have moved into an academic institution from the Pan American Health Organization, I do think that there is an urgent need for academicians to translate their knowledge to the policymakers and to make an explicit effort. I know that there are also structural things within academia that does not help on that, but I would say that is something that is badly needed. Really, a lot of the knowledge is not being translated to the community nor to policymakers. That would be one thing.
I can say, I mean, I came from the academic world not too long ago to government. I've never been in government until this job, actually, and so I understand more the academic world than I do of government service. You know, I think that there's a lot of fear within academia because we are pretty conservative, and I don't mean politically, but just in terms of the academic institution or medical institutions. And there's this fear of, well, what would happen if we step outside? And how do we really talk to policymakers? Do they want to listen? And I'm here to tell you that they really want to listen. And in fact, that if your voice isn't heard, some other voices are going to get heard instead. And it's so much easier than you might think. So I'll give you an example. Last week or 2 weeks ago was International Overdose Awareness Day, because there's an awareness day or week or month for everything, right? But at least in this case, so you've taken advantage of the opportunity. So we had International Overdose Awareness Day, and we invited our entire federal delegation representing the Baltimore area to all these events. And you know, they gave me naloxone, I gave them naloxone. It was kind of fun. It was a good idea to involve them hands-on in all the various things that we do. And we also invited leaders from our academic institutions and students to volunteer to do outreach trainings and to also educate our policymakers. And I realize this is a small example, but I think that that's one way to really get yourself into these conversations as students and practitioners and professors and researchers in a way that's really tangible, because you can see that it's not that scary, and also that then builds that relationship for you to not only advocate on that one issue that you're there for, but also on the larger issues as Dr. Frank mentioned, on environmental health or ACA and other things too.
Yeah, maybe while you're coming to this lady who's next, just having been in the Clinton administration on health, I think one of the things that comes up very clearly is really the federal government has very few levers in the public health arena. It has traditionally been, historically, for a very long time, really local and state government led. And so I think that's a dilemma, but you want to know where to go to try to get the issue taken care of that you have to get taken care of. And then the other thing I would encourage, and I would imagine any school that Anna's associated with for very long, will be looking at explicit training of public health professionals in the process of translating evidence into actionable implementation, actual interventions for policymakers and program leaders. So those are two challenges, I think, that are well suited here. Yes, ma'am.
Thank you so much for what you've said. It's been really lovely to hear so many different ideas and different perspectives. I'm Jana Mossy, and I'm a faculty here in epidemiology and biostatistics. I'm an epidemiologist. And you've mentioned, a couple of you, things about the homelessness, the mental health problem, the substance abuse problem. And the question I'm really raising, or the issue I'm raising, is that I see worldwide that mental health is one of the most important limiting factors for the population at large. And the World Health Organization has been talking about major depression as one of the leading causes of disability worldwide. We have suicide is getting to be higher in the causes of death in multiple populations. I see us as in public health, as the politicians, as almost everybody, having that be sort of like the big elephant in the room that nobody really wants to talk about, and very little seems to be progressing and being done about it. I mean, the same things, the World Health Organization came out with a major depression issue 10 years ago, or before that, and little has changed. And I'm sort of raising this as a question: how do we as public health become more engaged? I don't know that we are. We have very few programs in psychiatric epidemiology. We have minimal funding relative to other areas. And what do we do both locally and at the city level to bring this to the forefront of something that becomes not the black elephant or the big elephant in the room, but something we're actually making progress with?
Okay, thanks.
Well, I'll offer one first solution and pass to Mary some multifactorial solution that's needed. Like a lot of problems that we've been talking about, I think that mental illness has gotten segregated. So I think part of why we don't talk about it in public health, and we should be, is that it's gotten focused as, well, that's the mental health community, right? And so it's dealt with as a narrow clinical problem, instead of what it is, which is a broad social community problem. And it's dealt with to the extent that it isn't ignored, and a large part, as you say, is ignored. But to the extent it's dealt with in a narrow clinical focus instead of a broad focus that takes into account the impact of mental illness on the people around the person who's mentally ill, and the solutions for mental illness that go beyond the medication, right? That the treatment for mental health is most effective generally when it includes both medical realms and community treatment, socialization, empowerment, recovery, connection. And so I think that at least one solution I would offer is that if the issue is going to be dealt with, it's going to require public health people to engage more with mental health people and show them what each side has.
So this is really a timely question for us in New York City. The First Lady of the city has committed herself to leading the charge to changing the relationship between city government and the mental health of our city. And she uses the same phrase you just used, that mental health has been the elephant in the room, and that we have not successfully leveraged all of the tools of government to ensure that we acknowledge the many ways in which mental health intersects with many other activities that our taxpayer dollars pay for. So the criminal justice system, there was a behavioral health and criminal justice task force that came up with such ideas as drop-off centers so that police don't face the choices of a jail, a hospital, or a mental health shelter, homeless shelter, that they can bring somebody to a place where they could be connected back to care. The health department is going to be establishing those sorts of ideas, retraining frontline workers so that they understand mental health. That came out of the task force. Additional funds went into this problem of violence. This is something that it would help a lot to help us in city government understand how well we can predict violence, by the way. It's something that I'm not sure that politicians understand how poorly we can do that. But in any case, and finally, a roadmap will be released. I believe this is not public, but it's in the first week of November is the date that I'm hearing, which will talk about how we can mobilize city resources, the city workforce. You know, listening to my colleagues, New York City is a really big city. We have 350,000 civil service workers. Our health insurance coverage covers 1 million lives. So using our workforce as a major employer in the city to ensure that people are aware of mental health shows real possibility. That's one of the ideas. There's going to be a whole host of ideas, and I think this will probably be a legacy issue for the de Blasio administration. Academia has helped us in framing the problem, and I'm sure we'll turn to academia also for looking for solutions.
I think there is
Everybody else has a...
Yeah, we got more mics than we need.
More mics.
Except she doesn't, but we do.
I think there is a growing awareness of the importance of mental health as a public health concern. When our department a couple of years ago did its initial community health improvement plan and solicited input from a broad mix of different constituencies, one of the 3 priorities that emerged from that process was the need to better integrate mental or behavioral health and primary health care and other public health services. And perhaps at a more modest scope, there are steps that can be taken. So for example, the mental behavioral health counterpart for the state Medicaid agency, which is delegated to the counties in Philadelphia County, they've made every effort to facilitate or make it easier for primary health care centers, federally qualified health centers, to incorporate behavioral health, mental health services into their services, and to be able to get to bill for that. Well, that's important. If the primary care providers can bill for that, then that's more likely to get done. Another example is we often touch the same people as our counterparts in the Department of Behavioral Health, which also addresses substance abuse. But we haven't taken the best advantage to be integrated. A great example is around hepatitis C and HIV prevention. We work with the same community organizations that they're working with around substance abuse. And so we've started a conversation about how we can better integrate and coordinate the things that we're doing that reflect the consequences of substance abuse that we're addressing with what they're doing to address the problem of substance abuse itself, often in collaboration with the very same grantees or community organizations.
Okay, I've been given the high sign for 1 minute, so I think we're going to have our last question and then have a break.
Thank you. Howie Frempkin from University of Washington School of Public Health in Seattle. Great presentations by each of you. Although each of you talked compellingly about partnerships, I was surprised how little talk there was about academic health department partnerships. Each of the 4 local public health leaders comes from a city where there is at least one, and in some cases a large number of academic public health programs. But the academic public health department didn't come up much. Just in the last few minutes of conversation, there have been a couple of mentions in specific areas such as mental health, of areas where the health department may team up productively with academia. But what I'd like to do is ask each of the 4 of you, Carlos, sorry, this is a local public health department question, either give the best example you can of a productive partnership with a university in your city, and or give us an example of an unmet opportunity, something that you could do in partnering with an academic institution that would help advance urban health.
So we collaborate with this university and many others in a variety of ways in terms of projects that are done with faculty, either because they've approached us and want to do something with our data or our patients, or because we've put out a contract. We have students that come through on various rotations. We tap members of the academic community to be on committees, et cetera, et cetera, et cetera. And many of the healthcare institutions with whom we work are deeply affiliated with academic centers. We're working now with the College of Physicians in Philadelphia to develop a community-wide grand rounds in public health modeled after CDC grand rounds, where we hope to engage people from a variety of different perspectives on a quarterly basis to address issues of shared concern. So there's a lot of that interface, but my gut feeling is that it could be better. It could be more strategic. We could take more effective advantage of that. I think one thing that would be great is to have more opportunities for faculty members to spend rotations with us. And let me tell you, one thing you shouldn't do is send me a letter that says, "Hi, Dr. Bueller, my grant's due in a week. Can you please sign the attached letter of support?" Okay.
Let's have a quick comment from our other panelists, Leanna.
So we have maybe a unique problem in some ways in Baltimore, that there is significant distrust of one of our academic institutions. I mean, for those of you who have read the book about Henrietta Lacks, you know that, and I know that there are people from Hopkins in the audience, but that there, I mean, that is an issue in our community. And there is the perception in our community, in particular by Hopkins, but also by other researchers, that research is being done on you if there's an academic institution that's involved. And we see it somewhat too, right? We do see people coming into our health centers, approaching us all the time saying, we have a researcher who wants to focus on this particular area. How can we do research in your health department on this one area? And so we've started to turn this around and instead say, you let us know if you're interested in working with us in some way. And this is for all academic institutions. We will tell you what we need your help with. Whether you give us a broad area, like I'm an epidemiologist, we will give you an assignment rather than you coming to us saying, this is the work that I want to do. And I think that's been effective for us so far. Academics haven't necessarily always liked it, but I think our community appreciates that form of collaboration in what we call reverse research day, rather than the research the other way.
Well, yes, and quickly. So obviously partnerships with any entity are a lot more complex than any of us have talked about, because this is not a new idea, and it obviously doesn't happen immediately. And part of it is the kind of issues that Leanna's outlined. I think that one of our best opportunities is using these place-based lenses, and we are then collaborating, looking at everybody who's working in that place and using data to drive the priorities for what needs to happen. And that's what's happening in the district office areas. Additionally, we do the same thing. We generate a list at the department of what we consider to be our primary research needs, and we distribute it. And we've had mixed success, because all of you in academia know that you're driven by your funding opportunities and priorities. But I think we can focus on a neighborhood and probably achieve the best thing there.
To add to what Mary said, I think we'd have to work more with NIH and CDC to get them to fund the sorts of things that would be helpful, because the typical conversation that I've had with great academic leaders, there's tremendous agreement, there's tremendous interest, but then it's very hard to find the grant that would actually support it, usually because the questions that we're interested in and the methods are messier. They probably would ultimately have more impact, but they often don't fit the narrow NIH guidelines of the tiniest little incremental gain in knowledge that someone could have.
And Carlos, a lesson from abroad as a former dean in Mexico.
Very quickly, Howie, I think there is something that can be learned from the experience of WHO and the more than 700 collaborating centers. What WHO does is make an agreement with an academic institution, usually, or even a Department of Health, and make an agreement for a 5-year plan on what are we going to do. In fact, the Comprehensive Mental Health Plan of 2013 that was agreed in the World Health Assembly was the first draft was work with the collaborating centers on mental health.
Okay, fabulous conversation. I could see we could go on for a really long time, but we have to stop and move on with the program for a break. Let me ask the audience to join me in thanking our fabulous colleagues for their work every day, as well as this conversation. Thank you.